I'm here with Syril Dorairaj. Cyril, I do MIGS. I do a lot of MIGS. I love doing MIGS. It's fun. In fact, I may even like that part of the surgery more than the cataract part of the surgery, but that'll just be our little secret. Um, I have colleagues. I have a few colleagues who are cataract surgeons who don't do MIGS, and you know who you are. I'm not going to name you. Um, and I tell them, I don't think that it's fair to be a cataract surgeon and not offer MIGS to patients who are coming in with, stable, mild to moderate glaucoma and medications. I mean, who would want it? And one of the points that they make is, look, there's documentation of IOP reduction with just cataract surgery. How do I know that MIGS is adding anything? You're going to answer that question for me today, Cyril, I'm sure, because you have studied this. Is trabeculotomy, is goniotomy doing anything?
So the first question is, you kind of like said, cataract and glaucoma coexist. And almost like 4 million cataracts are done in the United States, and out of which 25 to 30% of them, there is a coexistence of cataract and glaucoma, and it is mild to moderate. And if you look at the previous literature, like from 25 to 30 years back, whenever you do any kind of procedures on patients who have glaucoma, even as simple as cataract surgery, the glaucoma progresses. Patients, start losing vision. Their pressures doesn't come under control. So that's the basic idea. The basic idea is to see whenever you do an intervention, and there is a possibility if you are doing a cataract surgery on patients who already have glaucoma, if you can keep that glaucoma under control, that's the main thing. So all these new procedures that's been coming in since last 15 years, has been offered for patients who have coexistence of cataract and glaucoma. Trabeculotomy is one of them. We don't need complex, convoluted procedures, especially if you're targeting cataract surgeons to perform something. So at the same time, because cataract is a major thing for patients, when they undergo cataract surgery, they expect something, a better vision immediately next day. So in those patients, you want something which is very simple and also like safer. At the same time, their quality of life should be improved. So invariably, whenever a cataract surgery is done on a patient, their quality of life is improved. But on the other hand, if a patient has cataract and glaucoma, if the glaucoma progresses, their quality of life is going to get worse. So this is the basic idea of like introducing all these new procedures where patients who have cataract and glaucoma together, we can do something for them so that the glaucoma doesn't progress and their quality of life or even medication use doesn't get affected. Coming to the next part, the trabeculotomy. It's something very similar to what in 1930s Dr. Barkan introduced. It's like based on goniotomy. Goniotomy where it's typically done in primary congenital glaucoma patients where you go incise something, a membrane that's typically seen, that's known as a Barkan membrane or anything like that. It's a incisional trabeculotomy or goniotomy. But if you see literature coming from 1970s after, if you do it in adult glaucoma patients who have glaucoma, unfortunately, there is a fibrosis of this. You make an incision, there is fibrosis, and there is scarring that happens and the surgery fails. So this is where the newer advance in innovation or the surgical innovation in MIGS, that's where the KDB that's came into picture.
The Coke dual blade. I mean,
Cahoot
just when
dual
people
blade.
don't know what KDB stands
Yeah.
for. Yeah.
So it can perform ab internal excisional goniotomy. It's not incisional. That was what was done before. This is something different where you excise the trabecular meshwork. The difference is, we all know almost like 60 to 70% of the time, like when there is a glaucoma, there is a pathology that's happening in the trabecular meshwork. There is some sort of like a fibrillar material that gets deposited in the trabecular meshwork, and that kind of impedes or blocks the fluid that goes from the anterior chamber into the episcleral venous system or anything. But this idea of doing excisional goniotomy or ab internal trabeculectomy is basically taking out this part of trabecular meshwork and then giving access from anterior chamber to for the fluid to flow outside easily. So this is why patients who have coexistence of cataract and glaucoma together, and if you look at the ratio for almost like 25% of patients who undergo cataract surgery in the United States, they will be benefited from doing some sort of procedures like this.
So how do you? Yeah, so I want to hear about your study because I think it's going to answer my question. In this sort of mixed surgical context in which you're doing cataract surgery and you're doing MIGS surgery, uh, trabeculectomy, well, you're excising TM. How you know how much of the pressure reduction you can attribute to one of those components of the surgery as opposed to the others. So tell me about your study.
So you kind of ask two things. One is, can you compare? That's like how much is compared. This study is basically not a comparison. It's basically to look at how the study performs over time. Anything that we do, especially as we surgeons, when we operate, we look into the first thing is the safety. Immediately when we are operating, we want to see if it's safe and over time efficacy. Our goal was to see if the glaucoma would be stable over time. And then the next thing is the pressure reduction. Will it be stable or if the patient starts progressing over time? So the study actually looked into prospectively, looked into patients who underwent cataract and KDB goniotomy over 3 years and kind of like monitored what happens immediately if there's any complications or side effects, whatever. And then over time, intraocular pressure and then medication reduction was evaluated. So if you see the study there's a poster that's been presented at the academy this year, almost 71% of patients had a reduction of 31% of intraocular pressure, whatever the baseline is. So these were all treated patients, patients who had mild to moderate glaucoma, who had clinically significant cataracts, who underwent surgery. Their pressures were around 18 to 20, something like that. And then when they underwent cataract surgery, when the goniotomy was done on them, almost 85% of them were off medications. And then over 3 years, the pressures maintained. For 3 years, almost 71% maintained their pressures. So they were stable. And also, like, we kind of looked into visual fields and OCT, structural and functional monitoring, just to see if they're stable. But as you know, any surgery that we do, even a trabeculectomy or glaucoma drainage device, which is considered one of the best surgeries for glaucoma, that's like basically we are trying to reduce the intraocular pressure in these patients. They over time the disease itself progresses. If you look at the literature, the disease itself progresses. So we wanted to look into this new procedures that's coming in. There's not enough data that's there. There is published 6 months data and then 1 year data. This is almost like more than 3 years of data that's been coming out of here. So that is the basic idea.
So has it? I mean, I don't know what your practice pattern was before this study, but have the findings of this study changed the way that you manage patients?
It all comes down to our patients' quality of life. So that's what it comes to. Our practice depends on, like, I started doing trabeculectomy 22 years. It's one of, it's a procedure. It's not a complicated procedure, but you can do it, but it's a work that's done after the surgery also. It's more, patients have to come for follow-up. You have to continuously monitor the bleb. It can scar, it can fail. And almost 9 to 10% of them will have some sort of complications, especially some sort of blinding complications. When these procedures were done, it's the safety. The most important thing is the safety. So when you give this kind of information to the patients, you have somebody who have mild to moderate glaucoma patients. You don't want a bigger surgery like trabeculectomy to be done on these patients. There are 1 or 2 medications they're on. The idea is to stop the medication, improve the quality of life. Then this is the safest option for them. And over 3 years, we have noticed that we might need more data, but at this time, my is it a change in practice? I won't be doing cataract and trabeculectomy in patients at the same time who are 1 or 2 medications. It's safer to do procedures like this.
So I want to ask one last question, and I apologize because it is off topic, and it is this: have the findings of this study um, influenced your readiness to offer uh, KDB as a standalone, because KDB is one of, it's not the only, but it's in the minority of MIGS procedures that are codable as a standalone procedure in the absence of cataract surgery. Has it changed your opinion about doing KDB surgery for pseudophakic patients who require a little bit more, but may not actually require a trab, since it doesn't preclude your subsequently doing trab anyway?
That's a very good question, actually. So you're kind of touching two things. One is, can it be done as a standalone, pseudophakic patients, and also in severe glaucoma patients? Now, if you look at the literature, there is enough data that's coming in that KDB goniotomy can be done as a standalone, and it's as effective or more effective, actually, like it's more effective in reducing the intraocular pressure combined with cataract in patients who have severe glaucoma. There are two papers actually published in the last 2 years which kind of looked into, it's a multi-center study, which looked into whether this procedure, KDB goniotomy, can be done as a standalone and in severe patients. Yes, it can be done, and it's more effective than combined surgery. The other question that you asked is, when you compare it to cataract alone in these patients, whether it will be as effective, because there is literature. Because their ocular hypertensive treatment study kind of looked into patients who underwent cataract surgery, and they looked into, and then over time, the pressures were like 2 or 3 millimeters lower than what it was before. That indicates, but like there are multiple literature which came, and even I wrote an editorial on this, which says in patients who have open angle glaucoma, doing cataract surgery alone is not enough, because we don't have enough data in terms of diurnal intraocular pressure variability and structural and functional stability over
Yeah.
time. But if it's an angle closure patients, if it's a patients with angle closure who don't have a peripheral anterior synechia, and patients who are, like they have angle closure or positional closure, they will be benefited. There is studies from Eagle study which looked into patients who are older patients who underwent clear lens extraction, and the pressures were far less in those patients. So, angle closure, I think there is a possibility if there is no PAS. If there is peripheral anterior synechia and then there is increased pressure and the patient is on medications, I would recommend taking out the cataract and doing a goniotomy or goniosynovitis. It's like a 3-step procedure. That's what I would recommend.
Hey, this is great stuff. Sir, I want to thank you for
My
bringing
pleasure.
this topic to us, particularly relevant to my practice, but I'm representative of this segment of the membership too. And most of all, sir, I want to thank you for being so very generous with your time with me today.
Appreciate it. It's my pleasure. Thank you.